Thank you, ma'am, respected chairs, and everyone in the audience. My name is Parash Sapkota. I work as a data and research officer at HERDi International, and presenting on behalf of my team is our research titled Determinants of Wealth-Related Inequalities in Mental Health, a decomposition analysis of nationally representative household survey data. So without further ado, moving towards a bit of background information. So mental health has been in a rising trend since the past decade, and it's forecasted to be the same. Mental health, particularly anxiety and depression, are affected by numerous socioeconomic variables, demographic components that exacerbate their intensity as well as prevalence and distribution. Nepal, being low-income country, is marked by significant economic disparities, and these inequalities may intensify mental health issues. Investigating these issues is very critical to inform policies regarding those intersecting variables that are key to identifying these distributions. And Nepal Demographic and Health Survey 2022 provides this critical insights into these dynamics, having been the first iteration among many to include a mental health module in its core questionnaire. So the objectives of my research are to identify the determinants of wealth-related inequalities, quantify those socioeconomic disparities, and then decompose these inequalities to find the socioeconomic variables that contribute the most to these inequalities. So NDHS in its nature is cross-sectional. So the mental health module was implemented in a subsample of households selected for the mains interview, and all the men and women eligible in the household were taking the total sample to 12,355. The outcome variable of our study is symptoms of anxiety or depression measured by GAD and PHQ scales with cutoff points of 5 and 9 respectively. We'll be measuring inequality based on concentration curves and relative concentration index. We'll be finding out the factors associated with them using a multivariable logistic regression, and we'll be decomposing that concentration index using a rigorous decomposition. So moving on to this classification that I'm putting in front of you. This is a classification done by the National Statistics Office on their degree of urbanization report. It classifies all the wards of Nepal into rural, peri-urban and urban areas. So what's the necessity of this classification compared to what's already there in the study? So what happens is NDHS employs a very umbrella approach to distinguish rural and urban areas. All the wards, all the clusters within an urban municipality and the rural municipalities are segregated urban and rural respectively. But that's not how it works. Urban population and urban areas are determined by numerous factors, and National Statistics Office incorporate all those factors such as population density, the build-up coverage areas, which means the structures in that residence, and those proximities of those components together. So effectively dividing all the wards into rural, peri-urban and urban areas. So our study tries something new. We attempted to link the degree of urbanization report with the DHS clusters to identify and divide all the DHS clusters into rural, peri-urban, urban areas, which is a more robust method as used previously in DHS. So how do we do that? So there is a method called as point-in-polygon method, most probable value approach, as given by Perez, Hedrick, et al. So what we do is firstly layer the ward level save files of Nepal with the degree of urbanization attribution, dividing it into rural, peri-urban, and urban areas. Then we plot the urban and rural clusters. I'm not quite sure if it's visible here, but the black one represents urban clusters and purple one represents rural clusters. So what DHS does is to maintain confidentiality, they offset all those cluster values into 2 kilometers and 5 kilometers offset to maintain that confidentiality. So what we do is build up buffer zones to adjust for that offset. Now what we do is create a program to actually find the most probable value using the probability method. So whatever the degree of urbanization attribution is in the ward level save files, the program extracts the most probable value of their clusters based on area it occupies. And you can see that in my previous slide, if I am able to move back. So you can see that the NDHS classifies this cluster as urban, but you can see that according to the degree of urbanization report, it's nowhere near urban area. So that's one of the major drawbacks of major surveys that's happening in Nepal. They classify urban-rural categories in a very umbrella approach. So we tend to rectify that. So what the program did was classified all 476 clusters with an accurate prediction of 92%, and the rest 39% were recategorized based on further mathematical computations and visual inspection method. So you can see that after the classification, across all mental health outcomes and the severity, urban population had the greatest prevalence. And we can also see that it's widely prevalent of symptoms of anxiety and depression was the most in Karnali province, with least in Gandaki. And across wealth quintiles, you can see that it gradually decreases with increase in wealth status. So using Erriger's correction, we plotted the outcome variable symptoms of anxiety and depression against wealth rank. What this makes is a Lorentz curve with a line of equality in the middle. Anything that's above the line of equality says that the health outcome is pro-poor distribution in nature. So we can say that for both anxiety and depression cases, the outcome was pro-poor in distribution. When you look across all the residence type, you can also see that the most inequitably distributed was again in the urban population, followed by peri-urban and rural areas. So we also performed multivariable logistic regression methods to find the factors associated with mental health outcomes, and we found out that age, gender, marital status, and health status were varying in magnitude across all residence type. Youth age 15 to 24 were significantly higher, had significantly higher odds of experiencing anxiety or depression compared to those aged 35 to 49. And gender, across gender as well, men had consistently lower odds of experiencing these symptoms compared to women. So from the results of decomposition analysis, we found out that sex was the leading contributor to disparities in anxiety and depression symptoms, accounting for over 60% of all the variation across all residence type. So it basically states that being a male or a female would likely influence your probability of acquiring mental health problems. Similarly, internet use significantly influenced disparities in rural and urban areas, whereas marital status and occupation were notable factors in peri-urban areas. Education impact varied by setting, contributing positively in peri-urban areas, but negatively in rural and urban areas, reflecting that it's very much context specific. So the key conclusion and takeaway messages are, from all my results, it's quite clear that the proportion of mental health outcomes is pro-poor in distribution, and it's distributed more inequitably in urban areas. Sex, again, is the dominant driver of all these inequalities across all settings, and other factors like internet use and education varied by context. And what this suggests is addressing these disparities, particularly in urban areas with urban poor, requires a very strategic approach, looking at all those intersections and in a more robust method for equitable access to health and well-being. That will be all. Thank you for your patience.